Hello, sir. Hello.
Good evening, everybody. Welcome to this evening episode of Pursue. And we have Pursue 6P, which is liver, pancreas, and GI pathology. And we are streaming live from AIIMS New Delhi via Kolkata. And today the topic is epithelial neoplasm of the stomach and small intestine. And to talk on that, we have Dr. Shilpi Thakur, who is a postgraduate from PGI Chandigarh, a DNB. Right now, she is a senior resident in the Department of Pathology, AIIMS New Delhi, with several publications in national and international journals. As was told by my professor and head, Dr. A.K. Banerjee, long time back, that in a department, the most knowledgeable is the senior resident, the most adventurous is the junior resident, and the most cautious is the consultant. So right now, today we have the most knowledgeable, that is a senior resident, and a special senior resident who has both the jewel and the crown, done as MD from PGI and now doing a senior residency in AIIMS. And before I ask Dr. Shilpi to present, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Shilpi Thakur, ma'am, please share your screen and let's start. Thank you.
Good evening, sir, and good evening, all of you.
Yeah, just present now. Yeah, I can see your screen, right.
Okay.
Yeah, please make it full screen. Fine, please start.
So the topic that I'll be dealing is the epithelial neoplasm of the stomach and small intestine. So beginning with the topic, first of all, the most important thing that we need to differentiate in all of the biopsies or the specimens that we get is to differentiate between the benign and the malignant entities. So there are a few points which are very much important in order to distinguish between benign and malignant entities. So these are divided into these categories, such as first we need to see the architecture of the glands, then the cytological features, the stroma, and after that, after these morphological and features, we can justify our opinion by the IHC markers. So first of all, we see the architecture of the glands, whether they are preserved or not. If they are preserved, then mostly it belongs to the benign category. And if they have got the regular borders, of course, this is a benign feature. Then we have got the fused and cribriform glands. The more we see the fused and cribriform glands, we are sure that we are moving towards the malignancy. Come to the cytological features, which are nuclear ataxia, loss of polarity, and mitotic figures. So if these three are present, then malignancy is the most important thing that we should think of. Then we go to see the stroma. Stroma, if it is showing the desmoplastic reaction, which is fibrosis along with the inflammation, then it points towards the malignancy. And if we see the glands which are associated with lamina propria, this is the feature of benign condition. So after seeing all these, if we see the Ki67 index, if it is very high, then it points towards the malignancy, and also P53 mutation. If P53 mutation is present, then it points towards malignancy. So these are the criteria based upon which we can decide whether it is a benign or a malignant entity. But most of the times it becomes very, very difficult on small biopsies to determine the differentiation between the two. So coming straight towards the topic, now the first, just a small recap of the histology of the stomach that we see every day in and out. So this is the mucosa, which comprises of the gastric pit. I don't know whether you are able to see the arrow. I'll just so here, this is the gastric pit that which is present in the mucosa. Underneath, we have the muscularis mucosae, a thin layer of muscularis mucosae, and the submucosa, followed by the oblique layer of the muscle, circular layer, and the longitudinal layer. So here, the parts of the stomach which we know, all of us know. Now, coming to the epithelial lesions of the stomach, it's the three most common epithelial lesions are the non-neoplastic benign polyps, the non-invasive neoplastic lesions, which comprises of the dysplasia and adenomas, and third is the carcinoma. So just for the completion's sake, I have added the fundic gland polyp, which is a benign entity. Although polyps are being dealt separately also. So fundic gland polyp, it is a benign gastric epithelial lesion which consists of hyperplastic expansion of the deep epithelial compartment of the oxyntic mucosa. They are usually asymptomatic and they can occur at any age. They may be associated with the syndromes such as the familial adenomatous polyposis or the GAP, which is gastric adenocarcinoma and proximal polyposis of the stomach. And an interesting thing which is there, it is that it is inversely related to the H. pylori gastritis. And most of the sporadic cases, we have got the beta-catenin mutation. Now, the other polyp is the gastric hyperplastic polyp. So this one is mostly has got the strong association with the chronic gastritis. And the surface shows erosion, and there will be haphazardly arranged dilated fovulae in the background of loose edematous stroma. And there will be a lot of inflammatory cells that can be present. And they may harbor foci of dysplasia, and those foci of dysplasia may show P53 mutation. So what are the precursors? So we are most interested into the precursors because we need to diagnose the cases at an early stage. So precursors of the gastric neoplasm. The most important two precursors are the atrophic gastritis and metaplasia. Atrophic gastritis, what is the cause behind it? Like the long-standing inflammation. So inflammation can occur due to the infection by the H. pylori. This causes fibrosis in the lamina propria and or metaplasia of the native glands. Both of these are important. Now, this mucosal atrophy, this will lead on to both the disappearance of the glands as well as metaplastic transformation. Now, I'll deal with the metaplasia in a much detail later in my presentation. So, am I going too fast? Okay, So the mucosal atrophy, it results in the functional changes which affects the production of acid secretion of the pepsinogen and gastrin. And the most common pathogenic factor for this atrophy is the H. pylori infection, followed by the autoimmune conditions. So if we say atrophic gastritis, then it means that there is both atrophy as well as inflammation present. Now, this gastritis, there is the assessment, operative link on gastritis assessment, which defines the 5 stages of gastritis and with increasing cancer risk. And there is another assessment criteria where it focuses on the intestinal metaplasia alone, which is the operative link on the gastric intestinal metaplasia. Now coming on to the metaplasia, there are two major types of metaplasia, which is intestinal and pyloric. In pyloric metaplasia, it means that there is replacement of the specialized acid and enzyme secreting cells of the oxyntic glands by the mucus secreting glands present in the normal pyloric mucosa. So we are most concerned with the intestinal type of metaplasia, which is directly linked to the intestinal subtype of the gastric carcinoma. Now, intestinal metaplasia, it means that there will be replacement of the gastric epithelium by the intestinal epithelium. So, the intestinal epithelium, it includes both the goblet cells as well as the columnar mucin-rich cells. So, in the normal stomach, we have got the mucin which is present is the neutral type of mucin. So, which will be pH positive, and there will be Alcian blue negative. So this pH-AB, that is pH and Alcian blue combination, is very important stain in order to find out the metaplasia. So based on this, this metaplasia can be divided into further categories as complete intestinal metaplasia or incomplete intestinal metaplasia. The complete intestinal metaplasia, it most closely resembles the small intestinal epithelium, and it has got brush border and goblet cells. Whereas the incomplete intestinal metaplasia, it resembles the colonic epithelium and it lacks the brush border. So this, based on the mucin histochemistry, now there is a difference between between the mucin of the small intestine as well as between the mucin of the large intestine, between the two. So sialomucin, which is mostly secreted by the small intestinal mucosa. So this is a acid mucin which is pH positive, Alcian blue positive at pH 2.5, but Alcian blue will be negative at pH 0.5. So this is mostly present in the small intestine. Whereas sulfomucin, which is a strongly acidic mucin, which is weakly pH positive, and it is Alcian blue positive at the pH 2.5 as well as positive at the pH 0.5. So this is a distinguishing feature between the two. And so based upon this, metaplasia can be divided into three categories, which is type 1, which is complete small intestinal, sialomucin secreting. So if we do the pH-AB stain, then we'll get it is positive for the Alcian blue. And type 2 is incomplete, and this is also sialomucin secreting. So, and type 3 will be incomplete sulfomucin secreting, which is most prone to the neoplastic transformation because it is having the colonic type of metaplasia. So before that, I have already explained what does it mean by complete and incomplete. So when we say complete, that means it will resemble the small intestinal epithelium with the presence of the brush border in the goblet cells. When we say incomplete, it means that it will resemble the colonic epithelium and it will lack the brush border. And based on the mucin, these are the three categories, type 1, 2 and 3. So this is just a repetition of what I have said. So type 1, again, complete or small intestinal type, composed of columnar crypts, absorptive enterocytes, sparse goblet cells, with or without Paneth cells, and intestinal type of endocrine cells. Whereas type 2, that is incomplete, and this is sulfomucin negative. So what is present is sialomucin is present. So it consists of the goblet cells scattered among the gastric, foveolar and neck cells. Type 3 is incomplete, sulfomucin positive, so resembling the colonic epithelium, and it shows the goblet cells scattered among the sulfomucin producing columnar cells. Now, this is one of the photographs, microphotograph, which shows the intestinal metaplasia. You can see the presence of these goblet cells, which is in the H&E stain. Now, this is the photograph where you can compare the H&E stain with the PSAB stain. So here, the black arrow, it denotes the presence of the goblet cells. So it shows a clear cytoplasmic vacuole, and the nucleus is displaced to one side, and then this is filled with the mucin. And this white arrow, it is the gastric mucus cells. When we do the PSAB stain, that is PS Alcian blue stain, so we can see that these goblet cells, this mucin-rich cells, they are stained blue. And here the mucus cells, these are stained as magenta. Okay. So now coming on to the next thing, after the gastric atrophy and the metaplasia, the next thing that we are bothered about is the gastric dysplasia. So it is also known as, in the WHO 2019, it is also known as the intraepithelial neoplasia. And it has been defined as, at this point I must say that all the things which I am presenting today are either from the WHO 2019 or the CAP protocol. So these are my source of presentation. So so this is defined as an unequivocal neoplastic lesion which can be depressed, flat or elevated, and without the evidence of stromal invasion. So this is very important because there is another entity which has got the invasion. So that defines. So this is a definition for the gastric dysplasia. So gastric dysplasia can be low grade and high grade, and the degree of differentiation is directly related to the gastric carcinoma risk. So the higher the grade of gastric dysplasia, the higher the risk for gastric carcinoma. So the pathogenesis behind the dysplasia are the chromosomal instability, microsatellite instability, CPG island methylation, or functional loss of CP53 gene, and APC mutations, which are most frequently found in the low-grade dysplasia and high-grade dysplasia, but they are less in the intramucosal carcinomas. So WHO 2019, it divides this gastric dysplasia into 5 categories. So in a small biopsy, when we see this plastic epithelium, then how are we going to report it? So category 1 is negative for dysplasia, where we are not seeing any kind of dysplasia or it is just inflammatory. The category 2 is indefinite for dysplasia. So what does indefinite for dysplasia mean? I'll explain it later. Then category 3 is a low grade, and category 4 high grade dysplasia. Category 5 is intramucosal invasive neoplasia or intramucosal carcinoma. So this entity is also important to mention. So the type of dysplasia in the stomach that we can see are mainly 2 types, intestinal type and the foveolar type. Foveolar type, that is a gastric type. So intestinal type, that is this plastic epithelium will be composed of the tubulovillous or the villous lesions, which are lined by the tall columnar cells, and the nuclei will be enlarged, elongated, stratified, hyperchromatic with eosinophilic cytoplasm. Now, on the basis of immunohistochemistry, we can distinguish between the two. So, intestinal will be having the same immunohistochemistry of the intestine that we can see. So, it will be MUC2 positive, CD10 positive, and CDX2 positive. Whereas the foveolar type of dysplasia, it will consist of the tubulovillous epithelial fronts and or serrated glandular structures, which are lined by the cuboidal to low columnar cells. Nuclei may be round to oval, and it can be have variably prominent nuclei. And the IHC, which can help in finding the foveolar type of gastric dysplasia, that is MUC5AC. They will be positive for this. So now the term that is indefinite for dysplasia. So where all we can apply this term? It applies to those situations where there is a diagnostic dilemma. So when we are dealing with a small biopsy specimen and it shows high grade of inflammation, we are not sure whether it is having dysplasia or not. So we can't straight away say that it is dysplasia, or not even we can commit that it is negative for dysplasia. So in such situation, this term has come for our rescue. So like for such situation, either we can do is we can evaluate the serial sections and see whether we are seeing any kind of dysplasia or not, or the best option would be to repeat the biopsy after clearing the inflammation. So either of these could be helpful. If the first one is not helpful, then obviously the repeat biopsy is a much better option. Now, the term intramucosal invasive neoplasia or the intramucosal adenocarcinoma, it refers to the neoplasm which invade the lamina propria or the muscularis mucosae. So, this thing we should keep in mind that this intramucosal adenocarcinoma, it is invading the lamina propria or the muscularis mucosae, but it is not going beyond that. So, so we this is the fifth, that is the category 5 of the WHO 2019 this, definition for the gastric dysplasia. So there are, so based on this, we have got the intestinal type of gastric adenoma, which is mostly present in the older patients, and it is associated with extensive metaplastic atrophic gastritis. And there will be etiology, mostly it is associated with H. pylori, autoimmune gastritis, and also it can have the APC gene mutations. So these are the two pictures. Here we can see that this is a low power view on my left side, and on the right side it is a high power view of the same. So this is a tubular adenoma with low grade dysplasia. So here we can see that the architecture, there is a little architectural distortion, but if we see that the nuclei, they are not very bad looking. They do have some prominent nuclei, but there is not nuclear stratification. Neither the glands are not placed back to back or fused or cribriform. So this is a case of a tubular adenoma with low grade dysplasia. Now this is another picture which is showing the high grade dysplasia. So here we can see the high mitotic figures and also this fused back to back placement of this crowding of the glands. And along with that, we have got this nuclear stratification is there, the elongated nuclei, and they are very bad looking. So this is a example of a tubular adenoma with high grade dysplasia. So now coming on to the gastric carcinoma straight away. So gastric carcinoma is the second most common type of the cancer which is present worldwide. And how do we define gastric carcinoma? So any cancer whose epicenter is more than 2 centimeters distal from the esophagogastric junction, that is into the proximal stomach, it should be staged according to stomach cancer, even if a gastroesophageal junction is involved. So this is the definition of the stomach cancer which is given in the WHO 2019. So we need to find the epicenter, and if it is more than 2 centimeters distal from the esophagogastric junction, then it is under the stomach cancer. So the pathogenesis of sporadic gastric cancer is multifactorial. H. pylori, which are positive for the CAG-A gene, now they produce high levels of interleukin 8, and they elicit intense inflammation, and which is associated with increased risk of the gastric carcinoma. Now, the other factors which are very much contributory to the gastric carcinomas are the diet, which are rich in salt, low levels of antioxidants, intraluminal formation of the N-nitroso compounds. These are the factors which help in the transformation into the gastric carcinoma. So coming on to the gastric adenocarcinoma, mostly they occur in 80% of cases it occurs in the distal part, that is the antral pyloric part. And the carcinogenic agents, as we have discussed earlier, the most common is the H. pylori infection. Second, rubber manufacturing industry, tobacco, smoking, X radiation, and the gamma radiation. So most commonly, the gastric carcinomas, they occur in the geographical distribution. If you see, then Japan has got the highest number. Now, so this is a flow chart which is like from how there's a transformation from a normal epithelia, and then how it goes to the chronic gastritis, atrophic gastritis, intestinal metaplasia, then dysplasia, and then adenocarcinoma. So all of them are linked together. So with the presence of the environmental and the host factors, the normal epithelium, which is if they are infected by the H. pylori, and also the gene, if the patient has got the gene polymorphisms or in the HER2, IL-6, and other genes, then it leads on to the chronic gastritis. Now, if the patient continues to have the high salt consumption, smoking, and then along with that there is immune response, the inflammation, which is a part and parcel of this. So this will lead on to atrophic gastritis. Atrophic gastritis, it can now, the transformation from atrophic gastritis to intestinal metaplasia can be stopped if there is ample amount of antioxidants. Now, if antioxidants are not there, then if the conditions, which is low acidity, CDX2 overexpression, genetic instability, all these will lead on to the intestinal metaplasia. And if intestinal metaplasia is combined with the APC mutation, P53 mutation, KRAS mutation, or the TERT expression, these are going to lead on to the dysplasia. Dysplasia will ultimately go for adenocarcinoma if these P53 mutation, MLHN, or these factors are there present, and ultimately the adenocarcinoma will be the end point. So this is how the various environmental factors, host factors, and the molecular events, they lead on to the formation of a gastric cancer. So the gross features of the gastric cancers, they are associated with the characteristics of the two main categories, like the early. So we divide this into early gastric cancers and the advanced gastric cancers. Now, what do we mean by the early gastric cancers? These are the tumors which are confined to the mucosa and the submucosa, with or without the nodal involvement, and these are called the early gastric. So they are easily picked up by the endoscopy. So early gastric cancers, they can be detected out easily endoscopically. So there are three main types of endoscopic appearance of the early gastric cancers, which are protruding, which is type 1, the type 2, which is superficial, and excavating, which is type 3. So this scheme, so if we see that type 1, then the metastatic disease to the nodes will be mostly rare in the type 1 form, and the type 3 will have the most probability of having a lymph node metastasis. So the early gastric cancer, it can be divided into these types, which is type B is protruding, type 0, now 2 is divided into 3, 2A, 2B, and 2C. So 2A is superficial elevated, 2B is superficial flat, 2C is superficial depressed. So these are so all of them are superficial. Now type 03, the excavated, it will be looking as an excavated portion under the endoscopic. So endoscopic mucosal resection, which is the treatment of choice for this early gastric cancers, and usually it is done along with the endoscopic USG for staging. So we can also see whether the lymph node involvement is there or not. Now coming to the advanced gastric carcinoma. The advanced gastric carcinoma, as the definition goes, it invades the gastric wall beyond the submucosa, and it can be further subdivided using the Borman classification. So this scheme, it is actually so this is a pictorial representation of this. So type 1 is the polypoidal outgrowth that can be seen. This is all the part of the advanced gastric carcinoma. Type 2 is ulcerating, type 3 is ulcerating/infiltrating. So we can see the ulcer with the heat ulcer borders and infiltration into the adjoining area. And type 4 is the linitis plastica, which is the leather bottle appearance. So this is one gross photograph. So by the look of it, we can say that this belongs to the type 3, which is infiltrating as well as there is an ulcer. So ulcerative as well as infiltrating because of this. So the presence of this heat border along the ulcer edge, it is denotive of the infiltration into the adjoining mucosa, and ulcer is a big ulcer is also present. So this is type 3 Bowman classification. So this is a gross photograph of the type 4, which is the linitis plastica. So this is actually the leather bottle appearance of the stomach. So this is all infiltrated. Now, based on the IFC, the 4 types of gastric carcinomas which have been proposed are the gastric, intestinal, gastric and intestinal, and null type. Now, so the based on the mucin, which is like the MUC5AC, which is most present in the gastric mucosa. So if it is present, it is positive, and or if it is positive for MUC6, then it is for the gastric type of the gastric cancer, and it should be negative for the MUC2 and CD10. Intestinal will be positive for the MUC2, or it can be positive or negative for the CD10 for the intestinal. And both of them, if it is like IHCs are present, then gastric and intestinal. Null if none of them are present. We are unable to classify any of these. So the other type of classification is the molecular classification of the gastric cancer, which is proposed by the Cancer Genome Atlas, and which are divided into 4 types. That is EBV positive, microsatellite unstable, and genomically stable, chromosomally unstable. So these are the 4 molecular subtypes of the gastric cancer. Now, so there has been some changes in the WHO 2019 classification of the gastric cancer. So what I have done is that the most useful or the most actually Lauren is the most the oldest classification of the gastric cancer, and the newest is the WHO 2019. So I've just tried to compare between the two. So what had been defined as the intestinal, now it has been divided into 3 types under the WHO 2019, which is papillary, tubular, well differentiated, tubular, moderately differentiated. Most common type that we find is a tubular adenocarcinoma. Now, indeterminate, which was there in the Lawrence, it is now tubular solid, poorly differentiated. So, diffuse is poorly cohesive significant cell phenotype or poorly cohesive other cell type, whatever it is present. Intestinal, diffuse or indeterminate, it can be mucinous and not defined criteria. Now, there are other histological subtypes in the present classification. So, the other histological subtypes are the adenosquamous carcinoma, squamous cell carcinoma. So, adenosquamous, when we say, then we need to find the squamous component as 25, at least 25% of the squamous component should be there. Squamous cell carcinoma, so it should not have any of the adeno components. So, no glands should be there. So, completely it should be squamous cell carcinoma. And we need to rule out whether it is the extension of the esophageal carcinoma that we are seeing, or it is a metastasis from any other squamous cell from the other organs. So, we need to rule out this in order to classify it as the squamous cell carcinoma. Undifferentiated carcinomas, so we are in this, which doesn't fall into any of the criteria. Mostly they can have the rhabdoid type of morphology, they can be INI deficient. Now, carcinoma with lymphoid stroma. So it has got a better prognosis, and this is mostly associated with the EBV virus, Epstein-Barr virus. The hepatoid carcinoma, so it will have large cytoplasm, prominent nucleoli, similar to the hepatic parenchyma, and also it can produce the ASP. So alpha fetoprotein levels will be high in the type of hepatoid carcinoma of the stomach. Now, adenocarcinoma with enteroblastic differentiation, adenocarcinoma with fundic gland type, and fundic gland type also, this can be having a predominant chief cell type or a parietal cell type or a mixed entity. Now, the micropapillary adenocarcinoma, this is very important because it has got a very poor prognosis, and also it is related to the high rate of metastasis. So this is one micro photograph showing the papillary architecture. So we can see the core, papillary core, and along with that, these are the cells. So this is a papillary type of the adenocarcinoma. Now, this is so on seeing this photograph, the most common thing that we can think of is the hepatoid. So it's looking like the hepatic parenchyma, the liver hepatocytes. So these are having prominent nuclei, round nucleus, and large amount of cytoplasm. So hepatoid carcinoma. Now these are having signet ring cells. They are poorly cohesive, and so this forms the poorly cohesive signet ring cell type. This is an example of that. Now, whenever we report the gastric carcinomas, then the most important thing is which the clinicians are interested is about the HER2 status. So they want to know about the HER2 because they're having the anti-HER2 that is therapy, that is the Herceptin. So whether it will be responsive to the Herceptin therapy or not, they want to know. So we know that this is a cell signaling molecule here, HER2 receptor, which is the human epidermal growth factor receptor. So when it combines with the epidermal growth factor, it leads down to the signaling downward pathway, which involves the RAS-RAF kinase pathway, and then this will lead on to the gene expression, cell motility. This is a normal cell in which this thing happens. Now, in a tumor cell, what happens that there will be HER2 oncogene amplification. So more and more number of HER2 will be present. So HER2 receptors, more and more number will be present, which will combine to more number of EGFs, and so this will upregulate the gene expression, cell mobility, and cell cycle suppression. So this is very much favorable for the tumor progression. So in those cells, we need to know in tumor cells whether there are HER2 overexpression is not. Whether they are having HER2 overexpression. So in those tumor cells only this therapy will work. So what are the methods by which we can find? So I'll tell you, first is the IHC. By IHC we can find the HER2 status. So this is HER2 is established predictive biomarker, and it's a HER2 therapy which benefits the unresectable or metastatic recurrent HER2 positive gastric cancers. And it also used to predict the potential therapy response. So those tumors which are unresectable, it is very important to know their HER2 status. And if the HER2 status is equivocal, like by IHC, if it is equivocal, then the HER2 in situ hybridization ISH is recommended. The next step is ISH. So this is from the CAP protocol which I have taken. This is the algorithm, which is first we need to perform the HER2 test by the IHC. Now HER2 is a marker which comes positive in the basolateral and the lateral membranous reactivity it shows. So if now what is meaning of the surgical and the biopsy specimen? Like in the surgical specimen, we consider 10% of the tumor cells. And in the biopsy specimen, tumor cell cluster comprises of 5 cells at least, which are together. So, if there is a strong, complete basolateral or lateral membranous reactivity in more than 10% of the tumor cells, then this is IHC 3+ positive. And there is no requirement for the in situ hybridization. So this is positive. So these are very much prone for the therapy. for a good response by the therapy. Now, when there is IHC, it is 2 plus, that is equivocal. Now, when do we call it as equivocal? When we have got the weak to moderate but complete basolateral or lateral membranous reactivity in more than or equal to 10% of the tumor cells. So, if it is present in as the weak or moderate staining, so that is ISC 2 plus. Now, in these cases, ISH is very necessary. That is the in situ hybridization. And also, the IHC, if it is 1 plus, then it is negative, and IHC 0 is also negative. So, when do we call it 1 plus? When it is faint or barely perceptible membranous reactivity present in more than 10% of cells. So, what is common between that? We are seeing it in more than 10% of the cells in all these, in the surgical specimens we are seeing. And in the if there is no reactivity, and if it is reactive, but it is reactive in less than 10% of the tumor cells, then it goes for the IHC 0. So here we can see that this is negative completely. There is no HER2 positivity in this. Here, this in the B, we can see that there is at least few of the cells, but they are like less than 10%, and they are very weak faint stain, so 1 plus. And C is equivocal, which is having in more than 10% of the cells, but it is moderate or weak kind of staining. Then the 3 plus would something which will look like this. So it will having complete basolateral and lateral membranous kind of positivity, and also in more than 10% of the cells. This is 3 plus positivity. So all of A, B, and also C, it will require the in situ hybridization, whereas the D won't require the in situ hybridization. It is fairly positive for 3 plus. Now, there's just a table in just to show the. It is just a tabular arrangement of what I said. So there may be some pitfalls when we assess this HER2 by the IHC. So gastric intestinal metaplasia or the epithelium next to the ulcer, it can show HER2 positivity. It can be a false positive thing, or the edge due to the edge effect, which is very common in a small biopsy that we see. So that is also a pitfall. And also non-specific granular or pericellular staining is present, then that we can't consider as the correct HER2 staining. Or if the HER2 is present as a diffuse cytoplasmic or nuclear staining, then that is also not correct. So these are the pitfalls. Now, what is the HER2 and the FISH? How do we assess? So in a cell, if the mean number of if there is amplification or not. So if the mean number of the HER2 signals per cell, if suppose it is more than 5.2, so in the C, we can see that it is 5.2, and step 17 signals per cell, it is 1.7. Just 2 signals, green signals are of the step, and the red signals are the HER2. So we can see that it is increased. So if we see the ratio, obviously the ratio is 3, which is a higher one. So it is amplification. And if STEP is the chromosome enumeration probe, so here we can see that in a cell, the number of HER2 is definitely more than what we can see in the in compared to the chromosome enumeration probe. Whereas if we see the figure A and B, so here there are 2 red signals, which is and 1 green signal, or 2 red signals and 2. So the ratio is somewhere between, it will be almost equal, and so it is not amplification. And now we can see in the B that here also this ratio is about 2 or 2.5, like that. So here also this is not called as amplification. So if it is like 5, more than 5, 3, like that, so ratio, if it is more than that, more than 2, then it can be called as the HER2 amplification. So this is how it is determined by fish. Now we come to, so I've already talked about the other histological site, that is the gastric squamous cell carcinoma, and it should lack any of the adenocarcinoma. So it's just a repetition of what I've already said. And it is associated with the poor outcome. Gastric adenosquamous, like both the components should be present, squamous component should be more than or equal to 25%. And yes, we need to rule out the presence of adenoid or microcystic changes which is within the squamous foci. So we should not consider them as the glandular, true glandular differentiation. So that is very important, because sometimes we see the microcystic change or sometimes adenoid change is present in the squamous foci. So we should not consider that as adenoid component. Now, so these tumors, genetic predisposition and the hereditary tumor syndromes, mostly which are associated with the gastric carcinomas, are the familial diffuse gastric carcinoma, so which is mostly caused by the germline mutation of the E-cadherin gene, CDH1 gene. Familial adenomatous polyposis, that is FAP, associated with the APC gene mutation, Lee-Frommani syndrome, TP53 gene mutation, Peutz-Jeghers, associated with the STK11 gene mutation, and so on. So now the anatomic stage, it is the strongest independent prognostic indicator. But now we also need to know whether it is serosa and there is lymph node involvement or not. So this is the anatomic stage, which is very much important for the gastric carcinoma. So it is a very strong. And while grossing, we should keep in mind that at least we need to see 15 lymph nodes. Minimum of the 15 lymph node examination is recommended for the proper pathologic staging. So sometimes we just get 3 or 4 lymph nodes, so that is not accurate for the staging. Now, coming on to the other entity, which is gastroblastoma. Gastroblastoma is mostly, it is found in the young boys and young men, and it arises from the gastric muscularis propria, usually present in the antrum. Now, this usually has the biphasic histology, which comprises of the uniform spindle cells and uniform epithelial cells. In these, the mitosis is very rare. Now, based on the IHC, we can say that the epithelial component would be positive for the pancytokeratin, and it can show focus with the 56 and CD10 positivity. And spindle cell component, they will lack the cytokeratin positivity. Now, the only diagnostic feature is the presence of the MALAT1 and GLI1 gene fusion that is required for the diagnosis of the gastroblastoma. Now, so here we can see that it is arising from the muscularis propria. The epithelium, the mucosa is all right. It is not having any kind of dysplasia. So here we can see that the spindle cell component is there, and here the epithelial component arranged in these glands are present. So that completes our the epithelial neoplasms of the gastric cancer. Now coming on to the next is the small intestine. So small intestine, histologically we know that comprises of the mucosa, submucosa, and also the muscularis propria, serosa. Now the mucosa comprises of the intestinal villus. So mostly their function is for the absorption. Now so we come to straight away we come to the cancers, the adenocarcinomas or the epithelial neoplasms which are associated with the small intestine. So generally in the small intestine, it is the frequency of the adenocarcinoma is very low. And if at all, if it is present, then most commonly it is present in the ampulla or in the periampullary region. So the idea, so what has been proposed as like the presence of this bile acids and bile salts, because of them, there is increased risk of the presence of increased risk of carcinoma in the ampulla region. So if we just see this ampulla, how it is made up of, what is it made up of? So the extrahepatic bile duct and the pancreatic duct. So both of which, when the combination, when they combine, and the junction at which they combine, it gives rise to this dilatation, and this the opening of which opens into the duodenum. So this is known as the ampulla of Vater. Now this has been actually the ampulla word has been taken from the Roman flask. So Roman flask, which used to look like something like this, which has got two handles. Along with that, it is a dilated end here. So this ampulla of Vater, we are first actually concerned about the tumors which are arising from the ampulla and the periampullary region. So there is a reason behind this, because the prognosis between the two is different. So the prognosis of the cancers which arise in the ampulla, and the prognosis of the cancer which arise from the duodenal surface of the ampulla, that is the periampullary region. So they have got a different 5-year survival rate. So it is like 29% for the ampulla and 52% for the periampullary region carcinomas. So there is a huge difference. So we need to know whether the tumor that we are seeing is from the ampulla or it is from the periampullary region. So, so if we see, like most of the time, if it is not an adenocarcinoma, we can find that it is an ampullary adenoma. So ampullary adenoma can arise from that area, which is a polyp, which consists of dysplastic glandular epithelium, and it has got the it is within the anatomical or duodenal ampulla, and it can show either the pancreatobiliary or intestinal differentiation. So it is a polyp, and it will have dysplasia. It will be present in the ampulla and can show either the pancreatobiliary or intestinal differentiation. Now, the subtypes of this ampullary adenoma are these, in which there is intestinal type of adenoma with low-grade dysplasia, intestinal type of adenoma with high-grade dysplasia, non-invasive pancreatobiliary papillary neoplasm with low-grade, and non-invasive pancreatobiliary papillary neoplasm with high-grade dysplasia. Intra-ampullary papillary tubular neoplasm. So, what the degree of dysplasia is determined by the architectural complexity that we see, as well as the nuclear stratification and the nuclear atypia. So, these three factors we should keep in mind in order to rate it as low-grade or high-grade dysplasia. And what we are seeing, that there is a higher chance of malignant transformation in these ampullary adenomas, which than the other duodenal adenomas. Now, the IHCs, which can be used to differentiate between the pancreatobiliary and the intestinal. So predominantly MUC2 and CDH2 expression is seen in the intestinal pattern, and whereas the pancreatobiliary will show the EMA and the MUC5AC and the MUC6. Now, the expression of CK7 and CK20, it can be present in more than 50% of the cases in both of them. So they can co-express this CK7 and CK20. So after ampullary adenoma, the next thing that we are concerned about is the ampullary adenocarcinoma. Ampullary adenocarcinoma, since we know that the ampulla is the most common site for the small intestinal adenocarcinoma, and what specimen, so grossly what specimen we get is the Whipple specimen. Now, so proper grossing of this Whipple specimen is very much essential for determination of the origin of the tumor, whether it is the ampullary or it is the metastatic from the immediately neighboring regions of the bile duct and or pancreas. So we need to differentiate between the two. So that is why we need so the techniques which are followed the bread loafing, or also with the longitudinal bivalving. So what WHO says is that the bivalving method is a better one, because here we can see the exact origin of the tumor rather than the bread loafing. but in different institutes, different ways of crossing this Whipple specimen is follows. Now, periampullary duodenal carcinoma, they arise from the duodenal surface of the ampulla as ulcerative or vegetative mass. So, mostly they will have this ulcerative or vegetative mass. Whereas if we see the intraampullary carcinomas, they will be as subtle ulcers and the mucosa cover elevations will be there. The granular material will be protruding from the ampulla. So I could not include the picture, the cross picture of this, but I think WHO has got a very good picture of this. Um, then these can occur in two distinct subsets of these localizations, as from the IAPN, which is the intraampullary papillary neoplasm, as the polypoid nodular or granular mass, or from the ampullary duct. So if it is present from the arising from the duct, then it can be cirrus, constrictive, and there will be a circumferential tumor which will be localized on the wall of the ampullary duct. So these are the two distinct subsets on the basis of the localization. Now this ampullary carcinoma NOS is when we are not categorizing into any of these. So results of tumors of ampullary region, but they cannot be placed on any of the three categories which is above. And despite the proper gross as well as the microscopic correlation. So what are the histopathological types? So intestinal type, most common that we see, the pancreatobiliary type or the gastric type. Also the tubular adenocarcinoma with mixed features, non-tubular patterns, mucinous adenocarcinoma where more than 50% of the stromal mucin deposition should be there, poorly coastal cell carcinoma, medullary carcinoma, the same as we see in the colon cancers, adenosquamous carcinoma, high-grade neuroendocrine carcinoma, and mixed carcinomas. And if we see an undifferentiated carcinoma, they can have the rhabdoid morphology also and with the loss of eye and eye. So these are the few histological subtypes of the ampullary adenocarcinoma. Now coming on to the non-ampullary adenoma. So about 60% of the non-ampullary adenoma, they occur as a part of the familial adenomatous polyposis syndrome. And predominantly this will be intestinal type. Now, pyloric gland differentiation in non-ampullary adenoma are associated with the ectopic gastric mucosa, gastric foveolar hyperplasia, or Brunner gland metaplasia. And they are mostly associated with a GNAS mutation. And extensively, they express the MUC6 with variable MUC5AC expression. So, this is adenoma. And now the counterpart is the non-ampullary adenocarcinoma. So the most important criteria for definition is that it should lack the ampullary involvement, both by gross as well as microscopy. So so it should not be involving the ampulla. That is how we going to say it as a non-ampullary adenocarcinoma. Now, most commonly it occurs in the duodenum, and the etiological factors can be the chronic inflammatory disorders, Crohn's and celiac, the non-native milieu such as ileal conduits and the reservoirs, the exposure to the acid and bile, alcohol, smoking, and the hereditary causes which are the FAP, Lynch syndrome, and the PJ syndrome. So most of these are similar to what we see in the colon cancers also. And the molecular abnormalities are the TP53 mutation, loss of E-cadherin, SMAD4 KRAS mutation, and the IDH, HER2, CDH1, MET, FGFR2 mutation. So these are the molecular abnormalities which we can see in the non-ampullary adenocarcinomas. So I think most important thing that from exam point of view are the gastric carcinomas that we see, and also the adenomas, dysplasia, and practically the important thing is about the HER2 status. So I have tried to cover these topics in detail. So this brings us to the end of this discussion. think if there are some topics which I have left or which I have not included in my presentation, please do let me know. I'll try to cover it up in maybe some future class or something.
No. I think all the relevant points have been addressed and have been addressed fairly, nicely. It was a very nice presentation, very crisp, to the point, and whatever is required from the learning and teaching point of view has been addressed. And we can't address almost everything here, otherwise it will be a non-ending lecture. And it has been very wonderfully done, and you have put up your slides in a very nice way. Wonderful lecture, very nicely done, Dr. Shilpi. And we'll definitely ask you to talk on some other topics some other time. Definitely, you did a very nice presentation. And if there are any questions, I'll put it up in the Telegram group, and then you can answer them there.
Right, sir.
Right. So nice, very nice.
Are there any topic like which which I've not been able to explain or something?
No, explain
let me know.
Only thing I just wanted to thing is that all throughout in Whipples we have been trying to open it on the bivalve technique.
Yes, sir.
I don't know whether do you follow the bread loafing technique or you also use the bivalve opening.
So mostly we followed the bivalving only, but I remember during my yearship because people were of different views, so they were telling bread loafing is also one of the methods.
Yeah, of course. If you remember, Dr. Paramita Roy had taken a full class on grossing of GI specimens on this Pursue, which we have included in the grasp 1 category. So in that she had shown the Whipples and she had shown that how bread loafing was done, and but what we have been practicing all throughout was the bivalve. We opened it up to exactly locate the tumor and then proceed further.
Yes.
Both have their pluses and minuses. I mean, I think in what you call bivalve, you can control the number of slides you are making, the number of blocks you are taking. But in bread loafing, the number of blocks definitely increases.
Definitely increases, yes, sir.
Because you have to go from one end to the other. I mean, and go on embedding it serially.
So what I read from WHO was they also recommend this bivalving method over the bread loafing.
Okay, good, right. Thank you, Dr. Shilpi. Wonderful. With your hectic senior residency schedule, you've taken out time and taught us something very nice and good. God bless you. Thank you so much. Take care. Please do share your PDF so that we can share with the students. They will really like to have. Thank you. Take care. Bye. Good night.
Good night. Bye, sir.